Good afternoon, everyone. Welcome to another installment in our COVID-19 planning webinar series. Pleased to have everyone with us today as we continue to, in the best of our effort, address questions that are coming in through the staff email line, and as well bring forward topics that we know are evolving very quickly as our organization plans in the face of the COVID-19 pandemic. My name's Aaron Levo. I'm the Vice President of Communications and Public Affairs, and I'm happy to be moderating this session today with a number of my colleagues. As always, we'll be recording this session, and it'll be available after the fact for you to share or to listen to subsequently again. So please let me take a moment to introduce who is on the call with me today. Just waiting for the slide to move. There we go. With me today is our President and Chief Executive Officer, Rob McIsaac, our EVP Chief Operating Officer, Dr. Wes Stephen, our Vice President of Human Resources, Michelle LaRue, our EVP and Chief Financial Officer, Dave McKeag, our Vice President of Corporate Services and Capital Development, Kelly Campbell, and our Vice President Quality Performance and Chief Nursing Executive, Kirsten Kroll, as well as our Medical Director of Infection Prevention and Control, Dr. Dominic Meertz. Thank you all for joining me. I guess, Rob, as is the case on these webinars, I'll start with you. I know we're all watching the news and seeing the situation evolve. We're trying to keep pace with a lot of change in our organization. Can you give us a bird's eye view of what you're seeing this week?
Sure, Aaron. And I'm happy just generally to try to kick off the discussion today. I think HHS has accomplished an extraordinary amount in the last couple of weeks in anticipation of this situation. We've done things that honestly I didn't think we could do in such a short period of time in terms of ramping down activity and trying to create capacity for the wave of patients that we think is likely coming at us. I know there's lots of uncertainty around what we're facing, and that makes this even more difficult for all of us. This is an extraordinary moment for everyone, both professionally and personally. I think it's just frankly, I think it's a scary time, and it's worth admitting that. But our community is relying on us. They're relying on us for our courage and our commitment. I feel very positive about HHS's ability in both those regards to rise to this occasion. In doing that, I don't think there will be any substitute for our support for each other as we head into some very difficult times. I also think we can take a lot of comfort in knowing that HHS has such a huge amount of expertise and experience, and in all of the very detailed work we've been doing to try to prepare our response for COVID-19. And I think I'm hoping that those discussions today will provide some comfort to all of you as we go through the work we've been doing. There's no doubt that the worldwide nature of this problem is creating a multitude of issues for us. I want you to know that as we make difficult decisions about our response, we are doing so relying on the advice of the best experts in the field. We are basing our decisions on the best available science. I also want you to know that we are doing whatever is necessary to try to meet these challenges. This is not about money, and it's not about bureaucratic rules. We are doing whatever we physically can to rise to this challenge. I do think this might be the biggest challenge any of us will face in our lifetime from a professional perspective. But I'm really proud already of the work being done and confident in our resolve to meet this challenge of a lifetime. I've already said in a previous session that thank you doesn't seem to adequately capture what it is that the gratitude that I feel to all of you for all the work that you're doing, but I'm not sure what more to say than that. So thank you, and I'll pass it back to Aaron.
Thanks very much, Rob. I guess let's start with a question to you, Dr. Mertz, about what we're seeing in terms of the data. I mean, we're all watching the news globally. We're seeing data almost every day in outlets about the spread of COVID-19 locally in Ontario, across Canada. I guess my questions are things changing? Are they getting better or getting worse? Maybe are we planking the curve, as it's been termed? Are we making a difference? Can you talk to us a little bit about that?
Thanks, Aaron. Maybe just starting with the numbers. So locally, Hamilton was sitting at 43 yesterday. I expect we will be around 50 today. They haven't updated the website yet. Ontario, roughly 1,000 cases. Canada-wide, 4,200 cases. You've probably seen in the media that we are now at more than 50% community transmissions instead of the way it was initially, with the vast majority of cases being linked to international travel. We are lagging behind in a positive sense locally. I would say we are 1 to 2 weeks behind of the epidemiology, for example, in Toronto, with still relatively limited community transmission, which gives us more time to react. We see, and we will continue to see, acceleration in number of cases, but as you can see, if we jump from 43 to 40 patients locally, it's still at a very low level at this point, and this increase will continue over the next few days, nationally, provincially, and of course also locally. Whether we can plank the curve, whether we can flatten the curve, too early to say at this point. We will see that impact over the next weeks. The physical distancing will have an impact over 2 more weeks. A, because of the incubation period. B, physical distancing will not reduce the number of family clusters we have. So it will need more than 2-3 weeks to be in this status of physical distancing before we can say for sure whether it has an impact on the curve or not. I just want to emphasize as well, physical distancing, you hear a lot about it in the media, what to do at home, to stay home, etc. I think one piece we can probably make a better job still is physical distancing in the hospital as well, not sitting together in lounges and spend a lot of time there, just to reduce the risk within our four walls as well. Thank you, Aaron.
Yeah, thank you very much for that, Dominic. So, you know, given the state of the play of things locally, and we have a little bit more time, that's some good news to hear, despite the fact we know that this is coming. How are we using that data to plan? Dr. West Stephen, can I go to you and maybe ask, you know, given what we know, how are we projecting that data using this time we have let's say over the next 2 to 3 weeks? Where will the emphasis be? How are we planning? Can you talk a bit about how we're getting ready in that time period?
Thanks, Aaron. Over the last few weeks, the team at Hamilton Health Sciences has spent some time doing what we call modeling. And this is essentially taking quite a few variables and trying to predict what the patient's demands or needs will be in our community. So some of the variables that are looked at is the patient population of Hamilton, the split of how many patients would come to Hamilton Health Sciences, the demographics of their age. Of those, what percentage of the population would we anticipate to get the COVID virus? Of that percentage of people, how many would require admission to hospital, how long they would stay in hospital, whether or not they'd require an ICU admission. And unfortunately, we know there's mortality associated with this disease. And so with all that modeling, which I must say, it is a best guess, it does inform our decision-making at the hospital of how have we been planning for the last few weeks. As most people should be aware of, there's been a lot of preparation that's been occurring. This has really been around twofold. One is to minimize the spread of the virus to the patients, to ourselves, our staff, and that has been significantly to reduce the foot traffic within our physical sites. And secondly is a focus around building capacity for what we anticipate, what we've seen elsewhere, and what we're modeling, the expected need of our hospital to meet the patients' and families' requirements or needs for care. From that, there has been task forces that have been created and have been extremely active, and each of them have had some tasks to perform from a planning point of view and executing some of those plans already. So the first one is led by Bruce Squires and Dr. Barry Lum, and it's the ambulatory care. The first phase of their activity has been really around decreasing the foot traffic within the hospital. This has been amazingly done over a very short order, pivoting to virtual care and trying to decrease the non-essential visits to the hospital. The second component of this work is really about consolidation or temporarily closing clinics, and to allow us to redeploy the staff and the PPE and the physical space, which will be no doubt required for some inpatient activity as part of our capacity planning. The second task force, which is the surgical or interventional procedures led by Les Gauthier and Dr. Stephen Kelly, has been to ramp down, which is consistent with the direction of the government, of all non-essential or non-elective work. We have significantly reduced our surgical program last week and this week, and anticipate this will continue for the near future. This is to build capacity for ventilators because some of the anesthetic machines may be needed to ventilate patients, to allow redeployment of staff, and to hopefully build some bed capacity. The next area of work is the transitions and decanting. This is really two major populations we're looking at, ALC patients and getting them placed in the community with support to once again to build capacity for us. And secondly is some of the non-ALC populations where there's active work to move patients into the community once again in a supported fashion. The last area, the second to last area is capacity by Cheryl Williams and Dr. Khalid Azam. And this is really about building an integrated plan, capacity plan for us to execute over the next 1 or 2 weeks. What I mean by integrated is that we bring all aspects of PPE, staffing, physician staffing, physical beds, physical space, into a plan that we can escalate as we get onto that curve of the patients coming into the organization. Of course, not to be forgotten on this work is the ethics and resiliency of whether that we are basing our decisions on best practice, but also on an ethical framework, and recognizing this is extremely difficult work for healthcare workers, for physicians and non-physicians, and the resiliency needs to be addressed as we go through this process. So I think what I would say is in the next couple of weeks, we will be executing our integrated plan, and that we anticipate that we will be starting to see significant increase of COVID patients. The last two comments that I would say to round out to answer this question is an old expression is to plan for the worst and hope for the best. But the second part of that statement is that I like to recognize that Hamilton Health Sciences is an outstanding organization with great people. And I believe we have it in us to do a phenomenal job, which we know is coming for the next weeks that are upcoming. So thanks, Aaron. I'll hand it over to you.
Appreciate that, Wes. I know, absolutely agree with your last statement. It's incredible to see the amount of work that's been done in the last, just in the last few weeks. And in order to get ready and absorb that first wave of patients, talking to colleagues across the organization about the things they're working on, it's astounding what we've accomplished together to get to this point in such a short amount of time. As that goes by, as that work is underway, it's also not lost on me that things are changing very quickly. One of the top questions we get through the staff email line is about where people can access resources, particularly clinical guidelines and educational materials. I know, Kirsten Krall, you spoke about this a bit on our last webinar. I think one of the things we've put together a slide, maybe you could speak to again where exactly these resources are located for people. I know it's really incumbent on all of us to go out and find this information and keep up to speed, but where would people go to look for that newest and greatest information?
Thanks, Aaron. Hi, everybody. So you've got a slide that's showing there of our COVID landing page and a little arrow there that shows a bookmark there around a clinical care guidelines. That's going to be our main source of posting documents that give direction around different procedures, for instance, critical care changes, what may be going on in the pediatric world, neonatal world, and so on. So that's where you will see more and more of the documents come alive. We are also posting them concurrently to our policy library. So you can search through either way. So the guidelines piece on the COVID landing page, you'll see a listing of these different policies and procedures come up. And then if you were to search through the policy library or usual policy library, you type in COVID, and it will also give you the listing of different procedures and policies that are on that site. It will be changing regularly, and with certainly the last few days, we're just getting ready to put a number of more major documents on that site. But part of this is also trying to make sure that we have the supports in place, because some of these changes are going to become much more sophisticated. And so keep looking at the site, and we'll make sure that we continue to get materials up there, but also creative ways to get that out as well.
Thanks very much. Yeah, there's a lot to keep pace with, and certainly we keep organizing the hub, and you can see there on that slide too other elements of the information available. It's the central place to go for all of that. So I guess another question for you, Kirsten, is around education. What are we doing as things change? How are we helping teams on the ground? What educational support's being offered for them to prepare for change at a local level?
Yeah, so the educators certainly are going to have quite a bit of presence. They usually do. They're big change agents for us. But we're also teaming them up with some additional people from other areas, namely, as an example, our OR nurses who are, with that schedule reduction of work, are coming into a process with our educators to be alongside to help reinforce some of the messages that are going out there. So we're really trying to look at some coverage, at least from 7 in the morning to 11 o'clock at night, to try and have people on site that can assist with those messages. So between the educators and some additional people working with them. So we're really trying to get that all teed up, including some weekend coverage as well. So it may be a little bit different between site to site at this point, but certainly the mainstay has always been the educators. And we're so grateful for that. The educators are also trying to make sure that, as they do usually, that there's scripting and there's consistency in messages. But we know sometimes it takes a lot of different paths for people to get the same message, and there are going to be variations between units depending on the patient population and so on that they're serving. So recognizing that sometimes can add some complexity as people compare notes, but we really needed to try and stay the course of what may be coming up in your own unit, because there are going to be variations depending on the nature of the business that you're in.
So I guess just from a practical level, if I'm working with a team and I have questions about caring for my patients or the proper PPE use, is that the educator I would turn to at my site to assist me in person?
At this stage, yes. Again, we're going to try and get some pagers or means to be able to reach out to these additional people as well. So again, that's just in the works right this moment, even contemplating whether or not we might create a phone line or something. But again, we're just trying to get that together. But for now, I would say turn to your educators. They are, again, trying to collectively make sure that they're on the same page as far as the messages. And keep in mind, this is always a moving target. So understanding the principles behind this is really, really important, so that people, again, a lot of talent and skill in our organization, we need you to use your judgment and stick to the principles that are behind these things to help guide the right behaviors. We can't think of every eventuality, but if people can make sure that they're on the same page around those principles, that will certainly help individuals.
Great, that's great advice. Thank you for that. I want to turn now to the topic of PPE and specifically masks. I know in media recently, government has been talking about their efforts to procure additional supplies of masks and other equipment. Every level of government is trying to position Canada or Ontario favorably in the global race for this. Kelly Campbell, can I ask you to talk a bit about that? What can we expect, and do we have enough of our own supplies right now?
Thanks, Aaron. Yeah, it really is a global race as we're all competing for a finite resource. But I can assure everyone we're working really hard on a number of fronts. Today, some of you may have noticed that we have logistics staff on the units doing a physical inventory. It's really important that we understand exactly where all our supplies are being stored, and many are being stored in locked areas, particularly PPE. So we're getting access to that today, so we could count and really understand our complete inventory, aside from what we know we have in our site receiving areas, and then in addition, what may be coming to us from our warehouse. We're also, though, closely collaborating with a lot of our peers. Sometimes to buy direct from China for some of this PPE product. These are very large orders, very expensive, and so we're trying to collaborate as much as we can to make these very large orders that we're not used to procuring on our own. We've had the community step up with tremendous support and have received a lot of donations of PPE from areas like the university, Mohawk College, and many other areas in the community that you wouldn't necessarily think having this type of product, but they do. So we've been very grateful for the support of our community and have really pulled in as much product as we can. That said, conservation still remains very critical because we have a long path to go yet. And as Kirsten's mentioned, the educators on the unit supporting any practice changes that we may see, and just really being conscious of how much PPE we are using, along with all of our efforts to procure more, should serve us as we move forward.
Thanks, Kelly. So let's talk about that then, conservation and our abilities to increase our supply. Kirsten, maybe if I could go back to you to talk a bit about that. How are we thinking about conservation versus use right away? Can you give me some sense of what that decision looks like?
Yeah, so people probably would have seen on the hub, or if you haven't yet, please go look. There's a guide document there, a number of strategies that are being implemented, both obviously in the organization, at the unit level, and then what we would hope everybody contribute to as well. Simply our reduction in volume of activity and restricted learners and so on are having impacts on that conservation. We're looking at alternative products, reaching out to the field to see what they can do to help us with that. At the unit level, you should have conversations about how workflow could change so that, as an example, you have fewer people go into isolation rooms. Maybe that is the primary nurse that's going in the room and MRP, but perhaps other team members are not going in, but can help look at how that team works together to still continue to meet the patient's needs as best as possible. So we really need teams to think about their CQI, the waste reduction kind of thinking that many of you are getting much more acclimatized to, applying that, thinking about, okay, how could we reduce the number of people accessing a room, putting on PPE? How could we think about some of our workflow on a unit? In other words, the movement between clean and dirty rooms. as another example. Maybe you need to think about runners in some cases if you have a lot of isolation patients, so that if they are cohorted, you know, an individual's going in, but if they need some additional supplies and so on, you could think about runners. Anyways, some of those ideas are certainly on the hub with a worksheet that units can work through to think of, again, the problem-solving approaches to find some different ways to do this. At the individual level, and everybody makes a difference in this situation right now. Everything that you choose to do matters in this current environment. So lots more guidelines are coming up around how we use that PPE. And of course, some of our routines that we're most used to are going to change because of the situation. We are going to be flowing out information about how people have an extended use of their products. In other words, if there is cohorting of patients with similar microorganisms in one particular unit, to wear that PPE between patients would be something we would expect. Some of these measures will be a little bit different in the emerge department, as an example, where again, the patient flow is a different story for them. So again, more of that guidance coming out, but you can expect to see that an extended use approach to the way that we have our masks and other PPE utilized will be coming through. Again, more standardization about that is happening, and the educators will help to flow that. The other thing that people are probably hearing about is reuse of masks. It is a measure that I would agree that everybody else is saying as well. We want to really hold that to something that's more drastic, because putting on PPE, taking it off and putting it on again, while it is feasible to do that, we need to have people do that well, so that you don't get contaminated. And again, we want to make sure that areas get the training, the guidance to do that. There are some materials on the site, again, related to the PPE conservation strategies that you can start to see the stepwise progression as an example, how to take on a mask, put it back on. But we really want to make sure that people can do that well. So make sure that you as a team are really contemplating that and really getting the education in place before you really go fully with that measure. But again, as much as the extended use for us is the big strategy right now, and again, people being on top of using their PPE properly, doffing properly, not putting on materials that are really not necessary at that point in time. The guidance around, you know, aerosol generating medical procedures and not, when is PPE required and not. I know that can be very confusing, but again, just to pay attention and keep pace with what that environment is like. And it will always be changing, and that's why we want to make sure the educators are out there with some supports.
So just to be clear, we're not suggesting reuse in every instance. This is a really specified and only very limited situations.
Yes, and again, I raise it because there's a lot of conversation, and certainly we have it in our own documentation. The public health group have also published a document in the last 48 hours that talks about reuse as well. So again, it's definitely a strategy that organizations may or may not be adopting. We're not saying go whole hog on that one at this point unless you've had some training or exposure to how to do this practice properly. Again, we need it to be done well.
Got it. Thanks very much, Kirsten, for that. Maybe if I could keep you on the hot seat and ask another question that we've been getting through the staff line a lot, which is about what steps I could take when I leave work and go home to ensure I'm not bringing any risk to my home or my family. You know, how do I keep my family safe when I leave work, I guess, is the basic question. I know we produced some a short little infographic document I think is on the screen now. Can you talk a bit about like what would be the standard practices that we would expect to see to keep people safe in this regard?
Think about the clothing that you're bringing to work, what you're wearing, and also changing into your work clothes at work would be the preference. Some of these principles are not new to our professional practices. Sometimes we've become a bit lax over time, but this would be best practices in any given time, but particularly important now. We don't want you to kind of wear your work clothes right out of the hospital and into the environment. So again, there are some strategies there around how to bag your clothing, get it washed when you get home. You know, think about putting perhaps your work shoes outside of the door instead of wearing them in your home. So there are some good tips on that. Even showering, again, good practice to get into showering after work, and making sure that you use always the hand hygiene message can never be strong enough. But there's some good tips on there that I think people may appreciate, and some things for me, even as I look at that list, I kind of go, yes, I could be doing that. So again, cleaning your devices, things that you hold a lot in your hand, all those touch points that are commonplace in our world these days, and being particularly attentive to that.
Great, good stuff. Dominic Mertz, maybe if I could ask you the last question, what's public health saying about people that might be, I might have a family member who's being tested right now. Should I come to work, or what's the guidance being given from public health or from an infection control standpoint about that?
Thanks, Aaron. Yeah, first of all, some reassurance. Most likely your family member does not have COVID-19. The vast majority of people who develop respiratory symptoms these days have the flu, have one rhinovirus, one of the other coronaviruses that we have around us for centuries, that just result in some minor respiratory symptoms typically. If your family member needs testing, then until proven otherwise, you consider it an exposed individual, and as such have to self-isolate until the test comes back negative in your family member. So you would need to stay at home and inform employee health at this point of time.
Thanks for that. And I guess while I've got you on the seat, what's the single most important thing we could be doing to keep ourselves safe right now from infection?
I think the single most important thing is hand hygiene and wearing a mask when we have contact in a healthcare setting with patients who are coughing.
Good. Well, I'm conscious of time. We do try to keep these sessions to 30 minutes so everybody can get back to the many tasks I know they have throughout the day as this as our effort to plan and respond to the pandemic continues. It's been long days and long nights for everyone, a lot of uncertainty, as Rob alluded to. We're all human and we're all dealing with this together. To address that, we're going to keep bringing information back to everyone through this format. We'll have sessions next week, I believe Tuesday and Friday again, to give you an update on what's the latest, what's evolved. We expect that there'll be a fast pace over the next couple of weeks as we continue to work with our government and system partners to implement the province-wide response that's underway. So our commitment to you is to bring that information through this forum. This session has been recorded, so you can share it with others that you work with. And in addition, you can always go to the Hub and download the Hub app to keep up to date with what's going on in our organization. So with that, I'll close this session and say thank you to all for participating. So please keep safe until we speak again. Thank you.